Hi, it's Dr. Centeno, and thanks so much for joining us today. As usual, what we'll do is I'll start with my brief presentation on the topic, and then you are free to ask questions about the topic or really anything else for that matter. Again, the goal here is to try to educate patients, because I find that educated patients tend to get better quicker. And in this particular Facebook Live, we're going to go over the PICL procedure for CCI, and I like to try to stay current on what's being discussed on social media. So a patient recently reached out and said, hey, you should probably know that this concept of the PICL procedure, which is the novel procedure I developed to inject the ligaments that hold the head on, to treat craniocervical instability or CCI, that there's some talk that procedure could inadvertently lead to dural leaks. So I thought it was a good topic to start out with today. And let's first start out with the concept of what is a dural leak anyway, right? I'm sure not everyone knows what that is. So your brain and spinal cord is covered by the dura, which is filled with fluid, and your brain and spinal cord float in that fluid. The dura can get a leak in it, and the fluid can leak out. And usually the most common symptom when that happens is a severe headache. But what's interesting about that type of headache is it goes away pretty much immediately when the person lays down, and is severe when they are up. So that's what's called pathognomonic for a dural leak. Now the problem is finding a dural leak is not simple, because most of them are very slow, and we have studies like radionuclide cysternography that are designed to see if they can detect dural leaks, but if it's a slow dural leak, it's unlikely to be found on that study. Dural leaks are also very difficult to find on routine MRIs. Meaning that you're looking for tiny fluid collections that could also be 10 other things. So it's very difficult to identify a dural leak on MRI. Now, oftentimes what happens is the dural leak is really firmly identified once it's fixed. And what I mean by that is the most common way to fix a dural leak is what's called an epidural blood patch. So it's to inject blood around the dura, which is the covering of the spinal cord, in that specific area of the leak. That acts as a physical barrier, and you're also putting platelets on the ground to help that piece or puncture in the dura heal. If that doesn't work and you have a chronic dural leaker, many times fibrin glue is injected in the same space. In our experience, if that doesn't work, platelet-rich plasma works well, as does bone marrow concentrate. So now that we know what a dural leak is, meaning it's when there's a small hole in the dura, let's talk about dural leak and injections. Probably the most common injection that can cause a dural leak, and it's pretty rare, probably 1 in 100 or less tries, would be an epidural injection. So if we're injecting epidural, that means we're injecting on top of the dura. And obviously, if we inject on top of the dura and we don't hit the dura, that's all good. That's where it's supposed to be. But if the needle goes too deep and goes through the dura, that can cause a small dural leak. Now, what happens next is really critical based on what you injected. If you injected steroid epidural or a corticosteroid epidural, then that little hole is inhibited from healing itself, because that's what steroids do. If you injected a platelet-based epidural, then you're actually enhancing the healing of that hole. And since those platelet-based products will also form a clot, just like a blood patch, you're treating the dural leak at the same time. Same thing with bone marrow concentrate. Now, if we focus in on the PICL procedure, the focus here is really not anywhere that's that close to the dura, although it would be theoretically possible to put the needle in to a place where it could puncture a small hole in the dura. But what it is you're injecting, bone marrow concentrate, will form a clot to block that hole and then provide the growth factors and stem cells to heal the hole. So even if that were to happen, which would be even more rare with the Picl procedure than it would be with an epidural, you are really injecting something that will help seal the hole. So it doesn't make a lot of sense that there's a lot of discussion about Picl procedure and dural leaks, because of the two things, even if they went hand in hand, and again, less likely than an epidural injection, you're injecting something that will help the leak. So that's sort of my take on dural leaks and Picl. So just to review again, we have the concept of a dural leak, which is a small hole in the dura, or the covering of the spinal cord and nerve roots. Those are very hard to identify. Do some treatment that could be injection-based or even surgery. And outside of that, dural leaks can happen with things like epidural injections, because you're close to the to heal a dural leak. So it's one of those things that is probably not a big issue. So let me start and go to some questions. Again, feel free to ask any question you would like, not just about this topic. So I'll start with submitted in advance by Harry Winston. Are some people more prone to dural leaks? Yeah, Harry, that's a good point. There's a companion blog listed in the show notes today. And if you click on that link, that'll go through all of that. But just to briefly discuss it, Ehlers-Danlos syndrome patients who have very stretchy ligaments would be more prone to dural leaks and more prone to what's called a spontaneous dural leak, meaning we don't really know why there's a leak. The person just sprung a leak. So yes, EDS patients are more likely. Submitted in advance by Raman Lanka. Can a dural leak be treated as an outpatient or does it require hospitalization? Yeah, Raman, the vast majority of dural leaks these days are treated with epidural blood patch, so that's usually an outpatient thing, meaning that the person goes in, gets an injection, goes home. The other nice thing about an epidural blood patch is the effects happen really quickly. In my experience, the patient is back up and doing what they like to do within 5 minutes because the blood clots there, and that forms a physical barrier to the leak. Megan May, can tendon or ligament heal back to bone if torn away? Megan, it depends a lot on the tendon or ligament that we're talking about and the extent of damage. So for instance, if there is damage to the ligament that's through and through, or what's called a complete tear, there are two kinds of complete tear. One where it's torn back like a rubber band and you have the two halves, in which case injection therapy is not going to be a good treatment for that. But a lot more complete tears actually still have fibers left. And in our experience, those types of complete tears are a great fit for injection-based regenerative treatments. Beth Rochford, any providers in New Jersey? We do have providers in New Jersey. If you just go to the Regenexx.com site, what you'll see there is a find a provider. And just look up New Jersey, and we do have people in the New York, New Jersey area. Now that's not for CCI, make sure you understand that, if that's what you're looking for, but for everything else. Jalal, I'm doing my second Picl with Dr. Schultz later this month. My DMX shows anterolisthesis of C2 maybe on 3 instead of C2 on C2. It says C2 on C2, but maybe C2 on C3. Indicating damage to the PLL, and I have distinctive instability in that area. When do you decide to treat the PLL and under what circumstances? Yeah, so anterolisthesis of 2 on 3 wouldn't necessarily be specific to the PLL. The PLL might be involved, but a ligament that actually has a much, much better lever arm, if you will, would be the supraspinous, interspinous ligaments in the back. PLL would be a higher risk procedure because we'd have to come anteriorly, go through and through the disc, and then inject only the posterior longitudinal ligament. So it's just risk benefit. So the big focus there would be on injecting these ligaments back here, see if the anterolisthesis goes away. If the anterolisthesis doesn't go away, then it's possible to inject the PLL. It's just higher risk to do so. So everything we do, I think as I've discussed in the show before, is always risk-benefit, risk-benefit. Kesley, I had a CSF leak last summer due to unguided upper neck injections that was treated successfully with a blood patch. However, I have been bedridden for the last 4 months because of severe pressure headaches that happen the moment I sit up and is nearly non-existent when I lie down. Pressure is also completely gone every morning when I wake up, but then it slowly increases with severity each time I get up to use the bathroom throughout the day. Should be evaluated for a blood patch. Yeah, Kesley, if you had a CSF leak due to an unguided upper neck injection, so let's unpack that first. So unguided upper neck injection equals bad idea, right? We've talked about that before. There's a lot going on up here, and you can do damage to the vertebral artery, which supplies blood to the back of the brain. You can obviously stick a needle in a nerve root or the spinal cord. All of that can happen if you don't use imaging guidance. So that would be below the standard of care. But what you're describing, Kesley, I think, is that you had a blood patch, and it doesn't sound like it possibly fully healed the leak. So the next step after a blood patch would be a high-dose platelet-rich plasma injection, epidural around the nerves there, and then to coagulate that PRP locally. So that ups the dose of the healing growth factors to hopefully heal that dural leak. Now, again, that's not a real diagnosis. That's a diagnosis obviously meant from just reading what you wrote. So you may have something else going on entirely, but if it is related to the dural leak, usually it's not a second blood patch. It's taking a step up and getting a PRP injection, epidural, and then coagulating that PRP. Stevie Ann Williams, is there a risk of dural leaks with posterior PRP injections? Not usually, Stevie. That would be even less likely. Again, less likely than an epidural. So when it comes to injections, the most likely injection to cause a dural leak, and that's probably only about 1 in 100 to 200 tries, would be epidural, because you're putting the tip of the needle close to the dura. When it comes to a posterior PRP injection, we're in the facet joints, we're in the ligaments, generally not close to the dura, so that's going to be even less likely than an epidural. Jalal, why do you favor PRP over or PPP over PRP to treat muscle trigger points? Yeah, Jalal, we favor PPP simply because of the basic science research showing that PPP helps satellite muscle cells, which are the stem cells in muscle, perform better than PRP. Hence, that's why we use PPP in the muscle rather than PRP. Adrian Cobian Barnhill. Kesley Merchant, okay, well that's a question for Kesley. Pia, sorry you came in late, so you answered already, sorry, does it mean that you do blood patches in Colorado? I might have a leak in the lumbar spine. Yeah, Pia, so we've done lots of blood patches for patients with dural leaks. The hard part about blood patches for dural leaks is doing a proper patch. And what I mean by a proper patch is you don't really know where the dural leak is. So let's say we're pretty sure it's in your lumbar spine. Let's say you had a lumbar puncture done at some point in the ER, and ever since then you've suspected a dural leak. So we have some idea that since lumbar punctures are generally done in the upper lumbar spine, that your leak is in the lumbar spine. In order to successfully treat the upper lumbar spine, we would need to do what's called a transferable epidural, probably at T12L1, at L23, and L34. So 6 separate injections, 3 on each side, to cover that area well in block. And that's the biggest problem I see is when people get blood patches, the docs tend to be a little lazy. They might do 1 or 2 spots because they got lots of patients waiting, or they're used to doing procedures every 15 minutes. And in order to do a proper, complete lumbar blood patch, we need to add a few more injections on top of that. So we might be at this for 40 to 60 minutes to completely patch lumbar spines? Yes, the answer is we do that in Colorado. If blood patches aren't working, obviously we go to PRP, as I talked about before. Stevie Ann Williams, I hit the top of my head really hard on a kitchen cupboard door. A couple days later, I had bloody watery discharge from my ear. My symptoms started after this, mainly heavy head and drunk feeling. Could this be a dural leak? Again, Stevie, the biggest pathognomonic is a medical word, but it means that there's something that's very specific about a diagnosis. So the pathognomonic symptom here is that you have severe headaches anytime you're up, whether you're sitting or standing, and the moment you lay down, boom, the headaches go away. The moment you get back up, boom, the headaches are worse. And I think someone had appropriately answered above here that, no problem at all, much, much better if she slept all night. Again, she was making cerebral spinal fluid all night, so she's got some extra when she wakes up in the morning, and then that's leaking out as she's up throughout the day. So if you have symptoms like that, and with the history of some bloody, watery discharge from your ear, it's possible you have a dural leak. But if you don't have those very specific symptoms, then it's unlikely you have a dural leak. Jalal, can you please explain C2 spinous rotation as seen in Dr. Katz's DMX reports? What does it indicate in terms of instability? Yeah, Jalal, if you go on the Regenexx.com website and you look up C1, C2 rotation, under the blog, you'll find the whole blog on that. But basically, since the C1, C2 joint, and one part of it is sort of a convex on convex joint, if you have any instability, one's going to rotate on the other because one part of the joint is going to be forced forward relative to the other. So all C2 spinous rotation means is that there's evidence of generalized craniocervical instability, or in that case, atlanoaxial instability. Rachel Riggs, thank you for covering all things CCI. Thanks, Rachel, for the shout out. Sharon Nilsson, hi, Dr. Centeno. 1 second here. Kind of jumped around there. Hi, Dr. Centeno. If one has anterior damage, do you always recommend try PRP first, and why? Sharon, I'm not sure what you mean by anterior damage. Do you mean the anterior longitudinal ligament? Do you mean the alar transverse ligaments? If you could explain that one, I'd be happy to answer it. Kesley, Adrienne, I believe I see. Okay, that's Kesley. Can increased intercranial hypertension is what we're talking about there due to CCI causing cranial leak in an EDS person. Olivia, it's possible. I don't know that we know for sure that intracranial hypertension can lead to a CCI leak in an EDS person, but it certainly makes sense. So it's possible that could happen. Deborah, could a leak cause POTS? Generally not those symptoms. Again, what we tend to see in patients who have dural leaks is this very specific symptom complex, meaning that they're not getting tachycardia when they get up. They're getting a severe headache when they get up, and then as soon as they lay down, the headache goes away. As soon as they're back up, the headache dramatically increases again. So not really POTS. Adrienne, is a long car ride 18 hours home discouraged after PICL? In other words, is the general bumpiness of a car ride harmful after PICL? Adrienne, I think a lot of that depends on if you could lay down. Obviously, if you could lay down, then might be not bad, depending on your route, I guess, if you're on a lot of highways. But in general, it's probably a better idea to take a plane, especially with COVID now burning itself out based on everyone from the WHO discussing that. So I think a plane ride would be better if it's possible, but if you could lay down in a car, not bad. Sharon, yes, I mean anterior ligament damage injury. So I think, Sharon, you're talking about the anterior longitudinal ligament. That can be treated with either PRP or bone marrow. A lot would just depend on what else we were doing. So if we weren't If we had a big tear, we would start with bone marrow. If we had a smaller area of laxity, then we would start with PRP. And if we were already doing bone marrow for something else, we'd probably just use it there and start with bone marrow. So that's generally how that goes. Kristen, I have injections in my PAO and other ligaments in my neck, but I also have a leak in my neck. Just to be clear for others, I had this leak prior to my injections from an injury. The injections just probably didn't cause it. I would still need to get a blood patch in my neck, correct? Or would the PRP perhaps heal it? You know, Kristen, I think a lot of that has to do with where the leak is. And the problem is that we would have to know or blood patch the entire neck. So it's possible to blood patch the entire neck, but that takes a good amount of time, energy, and effort. That's probably an hour by itself. And then obviously any other injections you needed to have. So a couple things. The first is we need to be really 100% sure that you had a Duraleak in your neck. It would be helpful to know where it is, because then we can focus our patching there. So that's probably the first part of that, is trying to nail that down. The difficulty is we don't have great studies, MRI, radionuclide cysternography, that can show leaks, but we can certainly try and see if we can pick it up on one of those studies. Probably a radionuclide cysternography study would be the best, but in my experience, that's hit or miss as to whether we'll find a specific spot. Sharon, to build on my previous question, what I mean when one has transverse alar ligament injury, what would going back here, would it make sense to try posterior PRP first? So Sharon, yeah, that's up to you. I can only tell you that there's only a small percentage of patients that have documented, let's say, alar ligament laxity, C1, C2 overhang, that kind of thing, who do a posterior procedure and then skip a PICL. So it's possible, it's just unlikely. So because of that, we've been tending to go more to PICL first. Having said that, if someone is less comfortable with PICL and wants to try a half step, I am A-okay with trying the half step, and that's all the posterior stuff first with PRP to see how that goes, and then they can make the decision after that. So a lot of that has to do with the low likelihood of success with posterior injections for certain patients. Also, though, respecting where the patient's coming from. And if the patient says, you know what, I would really rather do it this way, PRP posterior first, and then if that doesn't work, we can talk about PICL, I'm happy to do that. My goal is someone, obviously, that's comfortable with the approach and that we're both on the same page. Adrienne, my C1 and C2 are rotated in the same direction. Does correction of the C1 rotation help in any way with the C2 rotation? I'm not sure how they're connected. Yeah, Adrienne, if they're rotated in the same direction, then the question would be whether or not there was more severe instability, and that's something I'd have to look at on a DMX study. For instance, I saw one of those patients this morning who had a very large atlantodental interspace, really in neurosurgical range. We sent her to a surgeon. Surgeon didn't bite because she was otherwise functional, just a lot of neck pain and tightness. So we ended up doing a PICL, getting the transverse ligament, and the good news is that the ADI is down by about 60% after the first injection. So now it doesn't look like she's a frank surgical candidate, but she still has that uncoupling of what's happening at the skull and C1 and C2 because those ligaments are still looser than most. So it's possible that your ligaments are looser than most, and that's why you're seeing that. Kesley, is there anything I can do now besides lying down to help alleviate the pressure headache from CS leak before getting in for evaluation? Not many home remedies that I can think of, Kesley, for a CSF leak. So that's one I'm not sure that I can give you something for because it's such a gravity-dependent thing. Now, something that you could try, and I don't think I've ever tried this with a CSF leak patient, But you could theorize that if you were doing walking in water up to here, that the pressure gradient might be a little better. So even though you're dealing with gravity there, you may create less of a pressure gradient for the CSI leak, and that might allow you to be a little bit more active during the day and do some things with regard to walking in water. But I've not tried that in a Duraleak patient, so that's just theory right now. J. Vic hold on a second here. J. Vic had a follow-up from last week's posture discussion. I work 5 to 7 hours a day desk job. Posture is a huge issue for me with symptoms and recovery. Do you have any broad advice for someone like me with CCI who works in this setting? Is using a neck brace okay? Can working in this setting hurt recovery from injections? You know, Jay, I think the biggest thing there is to make sure that your number one, your desk is set up correctly. So that means that you're looking at eye level, not down like this on a laptop. Another big thing would be trying to make sure that your posture is supported by something like a lumbar support to keep you up like this. In addition, doing exercises, and I've got them on the Regenexx site, to open up the chest. It is big because we all tend to get tight in here because we do this with a keyboard all day. And then as far as a neck brace, that's a hard one because that's going to lead to weakness in those upper neck muscles, and so because of that, not really recommended. As far as working in that setting, hurt and recovery, a lot of our patients work in that setting, so as long as you're fighting against gravity, I think you should be fine. Sharon, can you inject the PLL and how? Yeah, Sharon, it can be injected, it's just higher risk, as I was saying above. So what I mean by higher risk is there's no way to get there from the back, so we'd have to come in from the front using an intradiscal approach, meaning going through and through the neck disc to get to the PLL. So we can do that, but it's higher risk because if we go too far, the spinal cord's right there. Another significant issue is that you're having to poke a hole in the disc and go through the disc in order to get there, which then increases the risk for things like discitis, etc., and or damage to the disc. So the answer is we don't need to inject it to get where we need to be, but it's possible to inject if we believe that there's no other way to help that person. Stevie Ann Williams, if someone needs more than one set of posterior PRP injections, how long should they wait between sets of injections? For posterior PRP injections, those can be done a little bit quicker than PICL procedures. For PICL, we're talking about at least 3 or 4 months between them. For posterior PRP injections, those can be done every 6 weeks or so. Any other questions, guys, I can answer. I'm happy to answer. If you want to type something in again, today we're talking about Duraleaks, Duraleak treatment, how they happen, and then a little bit about the various risks of certain procedures in Duraleaks, or anything else that's on your mind. Okay, I must have done a good job answering lots of questions. Okay, so we'll start wrapping all of this up now. Listen, I wanted to focus today on the concept of a Duraleak. What is a Duraleak? In addition, how do we normally treat those? What type of injections might be higher risk in inadvertently causing a Duraleak? Again, the most common one would be an epidural injection, and then after an epidural injection would be any injection where we're getting close to the dura. So hopefully you learned a little bit about that. Here's one more question here. One more question. Jalal, if we have anterolisthesis, retrolisthesis, plus some facet gapping below C3, we want the posterior okay, hold on a second. If we anterolisthesis, retrolisthesis, so I'm not quite sure where those are. Some facet gapping below C3, we want the posterior injections all the way down to T1, including the PICL. What would you inject? Bilateral facet joints and accessory ligaments. Jalal, this is a little bit too complex for this particular form. I'd really need to see your DMX to get a better idea of what you need injected. Adrian Covelin, Barnhill, if my instability at C1 to C2 may be worse than most, would your advice be continue with PICL? Yeah, Adrian, that's not a problem. Like I said, we just injected a patient who had an extremely large ADI, meaning that the dens was not connected very well to the atlas. She was clearly a neurosurgical case, and did just fine with PICL. So we're not seeing an issue as far as the amount of instability with PICL. Sharon, to put things in perspective, what is more risky, injecting PLL or fusion? That's a good question. I would say fusion is more risky than injecting PLL, but then you've got to get into the question of whether or not you need to inject it in order to get the result. And so if the answer is you don't need to inject it in order to get the result, then it shouldn't be injected. If you do need to inject it to get the result, then possibly it should. How many posterior PRP injections without bone marrow do patients need on average? Could it be possible to take few visits before you respond to it? Again, it depends on what type of patient we're talking about, but I think we're talking about CCI here. Normally, if we're talking about CCI and someone who's responding at that level, so that's the 1 in 5 that respond to a posterior PRP injection, usually 2 to 3. As far as taking a few visits before you respond, generally not. Patients generally respond out of the gate. We might go to a second one if they didn't respond to the first, but that's more rare. Kesley, thank you, Dr. Centeno. Thank you, Kesley. Stevie Ann Williams, further to my PRP question, if someone needed more than one set of stem cell posterior injections, how long should they wait between procedures? There, again, probably going to be more along the lines of 1 to 2 months, max 3 months for a bone marrow injection. If we're on the platelet side, quicker, more 4 to 6 weeks. Thanks, Jay. Okay, trying to see if there's any other questions. I understand there's some video feed issues that are happening intermittently. So we'll see if there's anything else here. Sharon, how is it possible one is very symptomatic with surgical measurements and other patients are not? I'm not quite sure what you mean there, but I think what you're talking about is whether there's a relationship between the amount of instability and symptoms, and the answer is not really. That's one of the things that makes medicine, certainly medicine in the spine, so amazingly unique, because we've got, let's say, people with awful looking MRIs that don't have many symptoms, and people with not bad MRIs that are very symptomatic. And the answer is that we have a structural neurochemical system. And that's one of the reasons why surgery sometimes is a little ridiculous, right? Because it deals with the structure, but it doesn't deal with the neurochemical part. So for instance, if nerves are pissed off, that's the neural part. If inflammatory chemicals are there, that's the chemical part. So it's structural neurochemical. And if we only have something that deals with the structure and doesn't deal with the neurochemical, it's probably going to be an inferior treatment no matter how you cut it, unless you get lucky, i.e. that the structure is the predominant problem. So that's one of the reasons that what we do is difficult sometimes, because it's one of the reasons why we can never just look at an image. That image has to be put together with how the patient got that problem, what their symptoms are, their response to treatment, physical exam, all of those different things in order for us to get a good picture about what's going on. So this idea that you can do a 3-minute cursory physical exam of someone, look at some images and plan a surgery is obviously ridiculous. It's one of the reasons why surgery's got a bad rap. There's people that really need surgeries, but many times the decisions are made simply based on structure, which is a really bad idea. David Iverson, hi Dr. Centeno, I want to know if patients with only CCI have a better chance of success with PICL than a patient with both CCI and AAI, whereas the PICL procedure is good as AAI as CCI. I think, Daniel, there's some confusion on terminology there. So CCI is the big circle, right? So that's everybody. And then AAI is a subset of CCI. Most of our patients have AAI. All of our patients have CCI, meaning that CCI is the broad term, AAI is the general specific term, meaning instability related to the atlantoaxial joint or C1, C2. So yeah, I mean, the patient I just talked about earlier who had the big ADI or atlantodental interspace had AAI as her primary problem, but that's also CCI. AAI would just be a more accurate way to describe what she had. So most of our patients have CCI and AAI. Some of them obviously have their instability only at 0-1, which would be not AAI, but that's still CCI. Sharon, can you actually say borderline instability can cause bad symptoms? Sure, yeah. I mean, anything can cause bad symptoms, meaning that if you've got an injured facet joint and a little bit of instability, you can have an immense amount of pain, and we're not going to see that injured facet joint on MRI. It's pretty much invisible. Or if you've got a pissed off spinal nerve and no instability or very borderline instability, you can be a miserable unit because your nerve is really driving your pain issue. Kesley, have you ever treated a CCI patient who suffers from abdominal wall dystonia? I can't say I have. We've had certainly CCI patients with various types of dystonia. So dystonia, obviously, in the cervical muscles. We've had patients with dysphonia or tightness in the abnormal tightness in the vocal cord area. We've had patients with dysphagia, spasm of the swallowing muscles. But as far as abdominal wall dystonia, that would be a new one. And then the question would have to get into what's causing the abdominal wall dystonia. Is it related to the CCI, or is it related to something else, perhaps in the back or the thoracic spine, etc.? So that would have to be, those layers of the onion would have to be peeled back. Pia, do you believe untreated CCI over time causes instability further down? I think what we see, Pia, is certainly that if someone has a long-standing neck issue, that can cause instability in other areas. So for instance, we know that patients with long-standing neck issues tend to have less ability to stabilize their lumbar spine. And then you can get lumbar spine instability that's muscular, and then that can lead to other problems. Sharon, calcification at the top of the anterior arch of C1. Can this cause symptoms on itself in a case of low BDI? Yes, Sharon, all calcification means is that I think in what you're describing here might be in some of those short ligaments that go between the atlas and the skull. But all calcification really means is that that area got beat up in usually an older person. And so the body is trying to reinforce it and it can't fix it, so it just throws bone there. It's usually not a cause of pain itself. In fact, it's the body's attempt to try to fuse the area. So bone spurs like that are usually not painful things. Now, is it possible that a bone spur can cause pain? It can in certain circumstances, but usually calcification is not causing pain. Can you please explain C1 facet joint effusion? Does it indicate instability at that joint, and could there be a cause for pain at that joint? Yeah, so I think you're talking about a C1-2 facet joint effusion. We always name facet joints with two of those indicators, C1-2, C2-3, C3-4. So a facet joint effusion just means there's fluid in the joint. If there's fluid in the joint, then what we're seeing there is a swollen joint, and swollen joints can definitely be painful. No different than if your knee joint swells up or your elbow joint is swollen. Usually that's associated with pain at that joint. So that needs to be figured out in a physical exam. And obviously if there is, we can take the fluid off and treat it. JVIC, I have this issue of calcification in my temples as well. Yeah, again, it just means that the area is getting beat up. And if the area is getting beat up, the body can either heal it or it can throw a bone at the problem. And so it just means that the area is beat up and the body tried to fix it but really couldn't get the job done. Kristen, yes, I mean injections didn't cause that. Thanks, Dr. Centeno. Okay, any other questions I can answer about anything? Sharon, the calcification, as I can understand, you see it only with old patients. What if you're in your 30s? Could it be just an anatomical variant that doesn't change? Yeah, Sharon, when I meant old, I meant really 35 and older. So meaning we generally don't see calcifications in teenagers. We don't usually see them in 20-somethings. But, you know, old from the regenerative medicine standpoint is 35 and older. So that's where the natural ability of the body to heal itself starts going down. So that's why we see NFL players and other athletes, for instance, not really lasting much past their mid-30s because their ability to heal goes down. So that's what I meant by older. And as far as anatomical variant, again, you know, the calcification is directly related to the forces on the area. For the time that that's been happening, meaning instability, and then obviously it tends to be more common as patients get older, i.e. Over 35 or so. So it could just mean that there's been a lot of instability in the area for a long time. That's one possibility. So that's the calculus plus time plus age. Jalal, facet joint. No, actually, if it's any effusion in a joint, if you treated, Kristen, when are ligaments most lax after? Problem with our internet connection here. Okay, I think we're back here. Apologize for the slow internet connection here. So Kristen, when are ligaments most lax after injections? Are you at increased risk to do more damage to yourself because ligaments are more lax after being injected? Ligaments usually aren't lax, so to speak, after injections. Normally you tend to see swelling in the ligament, and the ligament gets tighter. Then once the swelling goes down, then the ligament remodels. But as far as weakening the ligament through injection, generally doesn't happen based on what we see, unless of course that ligament was hanging by a thread or something like that. Pia, is it possible to get a PICL in neutral position without turning the head? Pia, that's possible. Generally though, if that's a big concern, what I'd recommend is that we only do the PICL from the front, keep you in a neutral position while we're doing it, and then not do anything else posteriorly until you get more stable, because anytime we turn a patient over, obviously that patient is sleepy and they're at more risk for having a potential problem. Stevie Ann Williams, if someone wakes up with a swollen shoulder and difficulty moving that shoulder, they previously had an operation to move calcification from here, do you know what might be causing this? It's a hard internet diagnosis to make, since there's about 10 different things that can cause shoulder problems or issues. So I probably need to know more, but generally swelling in a shoulder joint is due to osteoarthritis within the joint. And if they've already removed some calcifications from there, that generally means that probably, again, osteoarthritis within the joint. But again, other things can cause this type of clinical picture, so that's just a quick bedside thought. Any other questions I can answer there? Daniel, if coming over from Europe for the Picl procedure and ending up in a hospital after, will the insurance cover this type of new procedure or regenerative medicine? It's a good question, Daniel. We've never had that occur. So you probably just want to make sure that you've got insurance that will cover that. I don't really have a sense of whether or not the hospital will care why you're there if you're having this kind of issue. Now, I can't say we've ever sent anyone in recent memory to the hospital after a Picl procedure, but it's theoretically possible. So I think checking on your coverage, meaning you may want to discuss with the carrier that you're going to the U.S. for what's still considered an experimental procedure. If you have a problem related to that, is that covered? Sure, Stevie Ann Williams says thank you. Any other questions I can answer? Sharon Newsom, may I ask, what is the percentage of patients you see who did a CBCT? I'm currently getting treated by Ian Smith at Cairo. You said that since he has a CBCT machine in his practice, he says he sees a lot of patients with calcification of C1. Most of our patients don't have CBCT, but we certainly see a lot of patients with a routine CT, which would be a higher resolution film. So again, calcification. So let's now open up that topic because we haven't talked about that. So how common is it that we see some calcification in the upper cervical spine in CCI patients? And the answer is it's pretty common, meaning that probably about 1 in 4 to 1 in 3 of our CCI patients have some sort of calcification at C1, C2 in particular, usually coming up from the atlas or going down from the anterior atlas at C1. So that's not an uncommon thing to see. Other questions that I can answer?